Hello, my name is Brandy Garza. I'm an FNP student through Gonzaga University, and this video is being made as an assignment for the course Pediatric Nursing 652. The topic that will be discussed is pediatric schizophrenia. A typical scenario for pediatric schizophrenia would include a mother who brought her 17-year-old son, Joey, into the clinic because he recently started saying that the CIA was following him. He's very paranoid and struggles trusting new faces because he's concerned that anyone could be working undercover. The last 6 months, he's been withdrawn and spends a lot of time alone in his room. He was recently suspended from school for smoking marijuana during PE. Joey has known PTSD because as a child, he witnessed a murder of a family member. Schizophrenia affects roughly 1% of the population. Patients can have positive symptoms like delusions, hallucinations, disorganized speech and behavior, or negative symptoms, which include lack of motivation and social withdrawal. There's no specific cause for schizophrenia, but there are many associated factors that will be mentioned later. Pathophysiology includes overstimulation of the mesolimbic dopamine D2 receptors, deficient prefrontal dopamine, and aberrant prefrontal glutamate. Activity results in perceptual disturbances, disorganized thought process, and cognitive impairments. To diagnose schizophrenia, there must be a social and functional decline over a greater than 6-month period, and that's differentiating it between a brief psychotic episode or a schizophreniform disorder. You must have 2 of the following core symptoms for greater than a month: delusions, hallucinations, disorganized thought, grossly disordered catatonic behavior, and negative symptoms. The diagnosis of schizophrenia is greater in males, and the ratio is 1.4 to 1. The increased risk among men has been of interest to researchers, and some have suggested that it may be a result of higher drug abuse in men. There's a little bit of a range when it comes to resources mentioning common age of onset of symptoms and diagnosis. Generally, late teens, early 20s for males, and females early 20s to early 30s. All agree that childhood onset schizophrenia is a rare subtype. If a patient has a first generation relative with schizophrenia, the patient is 8 to 10% increased risk of developing schizophrenia. The objective physical exam for patients with schizophrenia is often benign. Mental status, abilities to answer questions, follow directions, and general behaviors are key to coming up with a diagnosis, in addition to reports from family about the patient's mood and behaviors and interactions. There's no diagnostic test to indicate schizophrenia. It is important, however, to rule out other causes like tumors, infections, encephalopathy, thyroid disorders, or diabetes. Comorbidities of schizophrenia include nicotine dependence in greater than 50% of the patients, metabolic syndrome and diabetes, HIV, hepatitis B and C, and marijuana can potentiate symptoms in the prodromal period. Multiple studies worldwide have found that depression, anxiety, and substance abuse are found more often among patients with schizophrenia than the general population. It's difficult to know whether these problems are part of the syndrome of schizophrenia or a result of having the illness. There are many differential diagnoses to consider, especially if schizophrenia is being ruled out in a pediatric patient. PTSD, anxiety, adverse childhood experiences, OCD, personality disorders are some of those. Children and adults have similar presentations, and sometimes it's hard to get information from children, and you may need to do multiple visits to gather that information to come up with a diagnosis and a plan. In addition to that, focus on building a relationship with the patient, avoid jumping to questions about hallucinations and delusions. Using drawings or other resources is necessary. Mental health disorders often occur subtly and are often first manifested as behavioral problems in school. Observe abnormal behaviors and refer to a pediatric mental health specialist if poor engagement, suicidality, or a concurrent substance use disorder is present. Long-term therapy is necessary with a diagnosis of schizophrenia. Pharmacological treatments include atypical and typical antipsychotic medications. The first-line treatment is atypical antipsychotics. Medications are based on clinical and subjective response and side effects. Other medications are mood stabilizers and antidepressants and benzodiazepines in the acute phase, not for long-term use. Therapies include the multidisciplinary care from both a primary care clinician and a psychiatrist. psychoeducation and psychotherapy for the patient and family, and then cognitive remediation is a new approach for cognitive retraining and psychosocial recovery. Vocational support programs have shown success in returning individuals to work, and long-term symptom management and rehabilitation depends on the engagement in ongoing pharmacologic and psychosocial treatment. Thank you for listening to this video. I hope it was helpful for your understanding of pediatric schizophrenia.